to 8:30.
Yes.
Tech team, can you give a call to Dr. Ajay and Dr. Chitresh?
Hello, Ji ma'am. I am Dr. Ajay here.
Yeah. Dr. Chitresh is joining Dr. Ajay.
Yes, ma'am. He is joining here.
Yeah.
Can you please tell him to join fast
We are-
because we are starting? Yeah.
Okay, ma'am.
Ma'am, we are live.
We are live? All right.
Yeah.
So, good evening to one and all. On behalf of the Indian Thyroid Society, it gives me immense pleasure to welcome all of you to another edition of the ITS Thyroid Clinics webinar series. So, as we know, the thyroid clinics definitely have become a very important academic platform where we discuss interesting cases, numerous clinical dilemmas, and also recent advances in thyroidology. So, this definitely is beneficial for clinicians, postgraduates, and to learn from experts all across the country. So before we begin today's session, let us just watch a brief video of the Indian Thyroid Society, which highlights our society's mission, its initiatives, and the impact it creates on spreading the awareness of thyroid health across our nation.
तस्य भासः सर्वमिदं विभाति.
So before we begin, I would like to acknowledge the leadership and the team of the Indian Thyroid Society for continuously supporting these academic initiatives. So the thyroid clinics is currently being conducted under the dynamic leadership of Dr. Pramila Kalra, who is the president-elect, and Dr. Roma Pradhan, who is the executive committee member. Also, we have Dr. Narendra Kotpal sir, who is the president of ITS, Dr. Arun Menon, secretary, Dr. Mini ma'am, the treasurer, always inspiring us and guiding us. We also have Dr. Chitra madam, Dr. Vijay Reddy sir as part of the thyroid clinics. So very short announcement before we proceed further. So we have the Thyroid Research and Practice, which is our flagship journal. So those who are interested to submit their research can do so by scanning the QR code, and those who are interested to become a reviewer for the same can do so by scanning the QR code. So this will help you sign up as a reviewer as well. So moving ahead with today's program's overview, our session will include a case presentation by Dr. Ajay Kumar, who is the senior resident in the Department of Oncosurgery from AIIMS Bilaspur. And the case discussion will be moderated by the distinguished faculty, Dr. Chitresh Kumar Sharma from Bilaspur and Dr. Anish Korsar from Trivandrum. And we will then have a very insightful presentation by one of the stalwarts in the field of endocrinology, Dr. Rajesh Kadgawat sir, who will deliver a talk on thyroid autoimmunity and pregnancy. This will be followed by a quiz conducted by Dr. Abhijit at about 8:50 p.m. So moving on, I'd like to introduce the moderators for the case discussion. So we have a very dynamic moderators for this particular session. So Dr. Chitresh Kumar Sharma, who is the additional professor and head of surgical oncology, AIIMS Bilaspur. He has numerous publications to his credits and has numerous awards as well, and has also been the author of a book named Evidence in Breast Cancer. So moving over, we have Dr. Anish Korsar. Everyone knows sir very well. So one of the very well-known figures in the field of endocrinology. Sir is the director and consultant of Capstone Obesity, Diabetes and Endocrine Services Trivandrum, and also sir is heading the Department of Endocrinology at Anantapuri Hospitals and Research Center, Trivandrum. Sir has also numerous publications to his credit and also been a reviewer of numerous journals, and also has been the author of a book named Living with Diabetes, a Complete Wellness Guide. So I request the moderators to take over the session and introduce the presenter.
Dr. Chitresh is available?
Yes,
If
yes,
not,
ma'am.
okay.
No, sir,
Dr.
I'm
Chitresh,
there.
can we start?
Okay, sir. So, Dr. Ajay is the senior resident academic SR doing MCH oncosurgery, and he is because of the load, we have a very much load of endocrine cases. So today he is going to present a case of parathyroid adenoma, and the unique thing is because even today we are struggling to diagnose the parathyroid carcinoma early. So the whole case is based on, the insight of the case is this case was diagnosed after 10 years because he was not suspected to having the parathyroid adenoma. So Dr. Ajay, please proceed with case presentation.
Sir, you're on mute.
Ajay, you are not audible. Dr. Ajay?
Yes, sir. Now audible, sir.
Yeah,
Ah,
you're
yes,
audible.
yes.
Go
Now,
ahead,
yes,
Dr.
yes. Now
Ajay.
you're
Yes,
audible.
sir. Now I'm going to yes, sir, again, sir. Today I'm going to present a case. The title is "The Hidden Culprit." Finally diagnosed 10 year of stone and broken bones. Now I'm going to present a case. Mr. Balvinder Singh, 38 year old male from the Roopnagar, Punjab, presented to our side with the chief complaint of the pain and swelling in the right thigh. The patient was apparently well until the present episode when he sustained a minor trauma in the form of a slip while walking, following which he developed pain in right thigh. The pain was sudden in onset, continuous in nature, and aggravated by movement of the limb. It was associated with the swelling over the affected region and inability to bear weight on the right lower limb. Following this, the patient was brought to the Department of Orthopedics, where evaluation revealed a fracture of the right femur. The patient subsequently underwent the surgical management of the same. During the course of treatment, another fracture was identified at the time of the shifting patient, for which second surgical procedure was also performed. Patient also complained of the difficulty in passing stool, and there is no any history of the high velocity trauma, chronic steroid use, prolonged immobilization, or malignancy. There is no history of the abdominal pain, headache, palpitation, sweating, excessive thirst, increased urination, increased water intake, or mood change and depression. Patient also give history of the fracture following minor trauma in 2023. And he also reported a history of a recurrent renal stone associated with the episode of the flank pain and passage of stones in urine since 2006, for which multiple urological procedure was done. In past history, there is no history of the diabetes, no history of the hypertension, no thyroid disease, no any tuberculosis or asthma. Having urological history for the disease standing done in 2023, and patient was SCB positive and taken treatment for 3 months. Patient having intermittent constipation and sleep and bladder appetite was normal, diet was mixed, and having addiction history for the IV drug use for 3 years, approximately 10 years ago. And patient also consume alcohol approximately 50 grams per day. There is no significant family history was there. On general examination, patient well oriented to.
Dr. Ajay, at the end of the history,
Yes, sir.
what are the differential that crosses your mind? We have a gentleman, a middle-aged man,
Yes, sir.
who is a manual laborer by occupation,
Yes,
and
sir.
he has sustained low-impact fractures.
Yes,
So,
sir.
if anybody who's sustaining a fractures when falling from standing height, definitely it is a pathological fracture.
Yes, sir.
So, in a short span of a week, he has had 2 fractures.
Yes, sir.
And he also gives history of multiple stones passing in the urine.
Yes, sir.
And what are the differential that cross your mind at
Sir,
this
actually,
point?
yes, sir. Differential diagnosis according to history, the classical feature was fracture right femur, recurrent renal stones, and history of the on and off constipation. My friends, I want to say that differential diagnosis could be the metabolic causes like hyperthyroidism, is like primary hyperthyroidism or secondary hyperthyroidism.
Hyperthyroidism or hyperparathyroidism?
Sorry, sir. Hyperparathyroidism. Yes, sir. Maybe primary or secondary hyperparathyroidism, or maybe due to long-standing osteoporosis can lead to pathological fracture. Others are like certain malignancy if there is metastasized to bone, and one rare finding like multiple myeloma can also lead to this type of the.
Now, first differential diagnosis is primary hyperparathyroidism. Before
Yes, sir.
1980s, we used to see such patients who just go on and on and on for a long period of time without diagnosis, and they develop such florid manifestations in hyperpara. But of late, I think now that there are more awareness among healthcare providers, and there is endocrinologists every nooks and corner of the country. And post 1990, I would say that hyperparathyroidism is never allowed to go this long undetected. Before that, it would have been picked up. So even though primary hyperparathyroidism is a possibility,
Yes, sir.
in this context, as you rightly said, we need to have metabolic bone disorders, at least a couple of them high up in the list. Now,
Yes.
malignancy with a long history of passing stones, is that possible? Because if someone has developed lytic lesions in the bone, do you think they will last such long period? Before that, they would have ran into severe problems. Then multiple myeloma is a possibility, but again, they would have had severe bone pain.
Yes, sir.
And recurrent stones are unbecoming of multiple myeloma. Pathological fractures, yes, but
Yes.
recurrent stones for a long period of. What other differential diagnosis do you have? I do not know, because I wish there had been endocrine postgraduates, because surgical, I do not know how to pose questions, but you can just try and at least a couple of differentials. You asked for nocturia, polyuria, etc.
Yes, sir.
And,
The negative
and
history
have
of.
you, if there is significant weight loss, nocturia, polyuria, etc., what else would you think? Can this be a renal tubular acidosis problem? Because we can explain recurrent stones, calciuria, nephrocalcinosis, a late manifestation.
Yes,
Because
sir.
renal tubular acidosis, acquired renal tubular acidosis, or mild variants of familial renal tubular acidosis can manifest in adolescence, but acquired can manifest at any time. But we can explain most of these problems, I suppose. Any other possibility? You asked for tuberculosis. Can sarcoid explain this?
Yes, sir.
Sarcoid, I think sarcoid is more likely to go undetected,
Yes, sir.
even now. It is a possibility.
Yes,
You
sir.
asked for, he has difficulty in passing stools.
Yes,
But
sir.
if he has recurrent loose stools, or any other possibility that you keep in your mind at this juncture, and a middle-aged man having recurrent loose stools, and recurrent stones, pathological fractures, weight loss, chronic inflammatory bowel disease could be a possibility.
Yes.
Tuberculosis of ileum and jejunum could be a possibility.
Yes, sir.
I think so. At this juncture,
Ajay?
probably we can say that primary hyperparathyroidism, as you very well stated, would
Yes.
be up in the list. Along with that, I think a couple of differentials like granulomatous disease, inflammatory bowel disease, a late manifestation of a distal renal tubular acidosis. Had this been presented at the age of, say, 7 or 9 years, what other possibilities would you keep in your mind? If this had been a presentation of a boy or a girl at the age of, say, 6 or 7 or 8 years, recurrent renal stones, failure to thrive, and fracture, then I think first up in the list would be renal tubular acidosis.
Yes, sir.
Renal tubular acidosis would come high up in the list. I think we need to work up for seriously look at the possibility of renal tubular acidosis. Then any hereditary diseases that you can connect?
Yes, sir. Can be hereditary in a man like a man-1 syndrome or man-2A syndrome. But
Men 1 and men 2. Men
but
now cannot be men 1, you mean to say? Yeah.
yes, sir.
Possible.
But
Possible. Any
but
other
man-2A syndrome, sir, can be.
No, apart from the MEN syndromes. Sir is asking any other syndrome
sir.
apart from MEN, any familial disease.
Where family
Yes,
is
sir.
very
Familiar,
important.
sir, familial hypocalciuric hypercalcemia may be
Very good. I think that is a
difference.
possibility.
Yes, sir.
Yes. Any X-linked diseases can you think of which can affect males only? No females, because it is an X-linked. Dent disease, X-linked hypercalciuria, where you can have this. Then hereditary hypophosphatemic rickets with hypercalcemia.
Yes.
These are only possibilities. This is for discussion sake. If the presentation is early on in the childhood, but here it is obviously these issues cannot sustain as a differentials because it is late manifestation. But still,
Yes, sir.
I think inflammatory bowel disease, because you have not mentioned anything about weight loss. So if I add weight loss, inflammatory bowel disease, TB or sarcoid involving the gut, and a late manifestation of or acquired form of distal RTA,
Yes, sir.
all are possibilities. Apart from, I think we can't go along with one diagnosis, isn't it? We need a couple of diagnoses.
Okay, sir.
Yeah. Go
Ajay,
ahead.
Sir,
Yes, sir.
so after sir has, guided you, now you can put at least 2 or 3 diagnoses in your patient. The first diagnosis is the first diagnosis differential is the primary hyperparathyroidism.
Yes, sir.
Second is
Second is
sarcoid,
according to sir's RTA, renal tubular acidosis, and inflammatory bowel diseases,
sarcoidosis or
sarcoidosis,
tuberculosis or inflammatory bowel disease.
inflammatory bowel disease.
So after history, always whenever you are presenting a case, after
Yes.
history, you have to put some differentials. Then you will present your examination, then you will cut down some, then you will go for investigation. Okay? So
Yes.
kindly proceed for your examination findings.
Yes, sir. On general examination, patient well oriented to time plus person, vitally stable. There was pallor was present, but ictus, cyanosis, and clubbing, and there is no any lymphadenopathy, and edema was absent.
If
There
there is lymphadenopathy and clubbing, what would it make any difference to you?
Sir, if there is a lymphadenopathy and clubbing, then we can think about the lung disease. Like I can think the sarcoidosis may be rule out.
Okay.
And
Go ahead.
Sarcoidosis,
Yeah.
yes,
tuberculosis may.
Yes.
yes, sir. On general examination, there is no evidence of any acanthosis nigricans, skin tags, or collagenoma, angiofibroma. There is no cutaneous lichen amyloidosis, or there is no any jaw swelling.
Why did you can I ask you, why did you ask for jaw swelling in this case?
Actually, sir, one diagnosis is that is name, sir.
Do you want to rule out anything, any
Yes, sir.
disease?
Yes, sir. Jaw tumor, one jaw tumor name, sir. Which is also associated with the hypercalcemia. Like jaw tumor name, sir. भूल रहे हैं सर अभी
Tumor induced osteomalacia, where you can get a jaw tumor.
Yes, sir.
But where it is hypophosphatemia, that is more important because of
Yes.
phosphate wasting and severe muscle weakness.
Yes, sir. Due to increased calcium levels in the jaw
But
tumor.
cystic tumors can come in as a late manifestation of hyperparathyroidism. You mean to say that probably?
Yes, sir.
Yeah, okay.
Orthopedic examination was done by the orthopedic department, suggestive of the right femur pain, shortening, and restricted movement. On neck examination, there is no any visible neck swelling. There is no scar or sinus. There is no any dilated vein. On palpation, thyroid gland not enlarged, no any palpable thyroid nodule, or there is no any palpable parathyroid swelling, or there is no any cervical lymphadenopathy was there. Trachea was central in position. Systemic examination, CNS cranial nerve motor system was normal. Bilateral normal vesicular very sound in respiratory system. There is no added sound. On cardiovascular system examination, S1, S2 normal, no any murmur. Upper abdomen examination, upper abdomen was soft, non-tender, no any palpable organomegaly, and there is no any renal brutes over there. According to history examination, we will summarize the case. Like this is the 38-year-old male who is presented with a history of recurrent renal stone since 2006, associated with episode of the bilateral flank pain and nausea. Recently, he sustained a pathological fracture of the right femur following minor trauma while sleep while walking, associated with a swelling and inability to bear weight on the right lower limb, for which underwent surgical fixation. During the course of treatment, another fracture was identified and managed surgically.
Now, at the end of your physical examination, now would you pursue with your primary hyperparathyroidism, or are you in a position to entertain another possibility, or what would be your differential at this point of time?
After history examination, we cannot say properly this is a primary hyperparathyroidism, because actually primary hyperthyroidism diagnosed by biochemically, not
No,
by the.
I think it is a medical question.
Yes,
Excuse me if I am asking in an inappropriate platform. Can this be Cushing's disease? Cushing's can have fractures. Cushing's can have hypercalcemia. I think leave it. I think you being from surgical side, I think forget
Yes,
about
sir.
it. But will you are you interested in looking for proximal muscle weakness?
Yes, sir. Muscle weakness can be there due to hypercalcemia. Yes, sir.
No, Dr. Ajay, Cushing has a proximal muscle weakness. So sir is asking if you are suspecting Cushing disease also,
Yes, sir.
then you should also look for the proximal muscle weakness and other signs of the Cushing disease, na? Skin changes and the fat distribution and all other signs.
Yes, sir.
So at the end of the history and examination, what are your possibilities, Dr. Ajay?
Yes, sir. Sir, according to history and examination, they presented the classical feature of like pathological fractures and recurrent renal stone plus constipation, but there is no any other feature of hypercalcemia. But this classical feature represent this can be the due to the metabolic bone disease. Cause metabolic bone disease causes may be uh, uh, my possibilities because this is towards the hyperparathyroidism. So.
You want to
Recurrent
keep the
stones, can I ask you something outside hyperpara? In this case scenario, a person who has recurrent stones and he has fractures, are you interested in his diet? What would you ask in the diet history?
Sir, can be due to vitamin D deficiency.
No, most likely from diet point of view, do you guess him a vegetarian or a non-vegetarian?
Yes, sir. Diet was mixed, sir. This person diet was mixed. Can take both.
So what are the leading questions would you ask in diet history, considering that he has recurrent stones and subsequently he has fracture? Okay.
okay.
When in stones, in renal stone, what are the food items that you mark to be associated or to be linked to of stone formation? Any suggestions? Like,
Sir,
oxalates are present in dry fruits, nuts, chocolate.
yes, sir. Diet
And
having
5Bs, we always say,
diet having more calcium or oxalate and phosphate, in which diet there is more calcium and phosphate.
yeah.
Dr. Ajay, we have left 4-5 minutes, so please go
Yeah,
ahead with the
I
investigation.
think, yeah, we will complete. Ajay, go ahead.
Hello.
Am I stuck or Dr. Ajay is stuck?
Yes, sir.
Okay, yeah. Move to investigations.
Sir, investigation calcium and phosphate.
No, please go
Your
ahead.
slides,
Complete your
slides are
presentation.
not moving. Ajay, complete
As
your presentation.
Yes, sir.
We have 3 more minutes left. Yes.
In investigation, hematology was done showing that hemoglobin was 8.2 and peripheral smear was showing that is normocytic normochromic anemia with macrocytes. In biochemistry examination showing the correctal calcium was 13.36 and phosphorus was 4.9, albumin 3.8 and intact PTH was 2077 picogram per ml and alkaline phosphatase was 559. Vitamin D was
Ajay,
20.
what was the ESR? What was the ESR?
Yes, sir.
Was it high? If you just offhand, if you can say above 50, above 100, because there is anemia.
Yes, sir. Yes, sir. It's
Are you remembering? If you have the reports, you can tell.
yes, sir. I have reports, sir.
Otherwise, you go ahead. As
Okay.
Yes, I have reports, sir. I can so. Yes, sir.
Okay, Ajay, we are running short of time. You
Okay,
please
sir.
complete.
yeah.
24-hour urine was in calcium was 148.5 milligram per day and phosphorus was 270 milligram per day and creatinine was 221.55
No,
milligram per day.
this calcium is normal or abnormal?
Sir, this calcium is normal, sir, in urine.
Yeah, this is normal.
Yes, sir.
Yeah, phosphorus is also apparently normal. Go ahead.
Yes.
Say in hyperparathyroidism, would you expect high calcium in the urine or normal calcium in the urine?
Sir, we expect there is hypercalciuria.
Yeah.
Yes, sir.
Vitamin D is normal. Okay, go ahead.
Yes, sir. Vitamin D was normal. And image finding X-ray showing that femur fracture with multiple bony deformity was there in X-ray
What are the
finding.
characteristic bone radiological feature of primary hyperparathyroidism? The classical presentation, as you said.
Sir, classical presentation is subperiosteal reservation and cortical thinning, sir.
Yeah. Okay. Go ahead.
And USG-QB showing that only suggestive of cystitis, small size right kidney, bilateral increased renal parenchymal echogenicity, and thick urinary bladder was there. Ultrasound neck. After that, ultrasound neck was done, showing that well-defined solid cystic lesion measuring 4 into 4.2 centimeter inferior to right thyroid lobe. After that, technetium 99 MEB scan was done and showing the large heterogeneous lesion, approximately 3.5 to 2.3 centimeter, with eccentric necrotic area near the right thyroid lobe. This is the system image scan showing that uptake in right inferior side of thyroid.
Dr. Ajay, what if there is nothing detected, picked up in the subtraction scan, what would you do? What are the options that you have? You have done everything and you sent for a subtraction scan, technetium maybe, and it has come negative.
Yes, sir.
What would you do?
Sir, then we can do 4D CT, sir.
Yeah, apart from that, 4D CT can be done.
Yes, sir.
Any functional imaging other than subtraction scan? FTG PET colon can be done. Okay, go ahead. Because we are running short of time.
This is also finding on the system maybe scan.
Okay.
Now it was concordant imaging, na?
Yes, sir.
So you just tell what did we do?
Yeah.
Yes, sir. And in DEXA scan, T-score
severe osteoporosis.
Okay,
this
it was
case,
severe osteoporosis. Okay.
yes,
Next.
severe osteoporosis were present. After this history examination and investigation, diagnosis made primary hyperparathyroidism due to the right inferior parathyroid adenoma with recurrent kidney stone and inborn severe osteoporosis and fracture. After that, we have planned for the treatment. Surgery was done. Focused right inferior parathyroidectomy was done on the 14 October 2025. An intra findings showing that a large 4 into 4 centimeter tumor was found behind the recurrent laryngeal nerve. This is a intra finding after removal of the parathyroid gland.
So we did a focus parathyroidectomy.
Yes, sir. We did
Okay.
focus parathyroidectomy in the cervical plexus block.
Okay.
Mhm,
What was the histopathology finding? अच्छा, okay. Post-op. Next
Yes.
post-op day. Post-op day 1 बताओ क्या है
In
improvement?
post of day 1, after parathyroidectomy, corrected calcium become 7.4 from the 13.36 in pre-op at the time of admission. Phosphorus become
Was the patient
2.6.
symptomatic? Was the patient symptomatic then with tetany or anything?
No, sir. In post-op period, no, sir.
But in the aftermath of hungry bone syndrome, this
Yes,
is hungry bone syndrome now. Don't you expect protracted severe hypocalcemia post-surgery? That is not missing here, no? That is missing here, I suppose.
yes, sir.
So,
Hungry bone syndrome can be common, sir,
Ajay,
but
you are missing one thing. We have when this PTS was dropped intraoperatively, we
yes,
have
sir.
started prophylactic calcium
Yeah,
supplementation in
that is
next.
what.
That is
Yes,
why
sir.
we are anticipating that this patient will
Yeah,
definitely do the hungry bone
I
syndrome.
think as Dr. Chitraj said, I think you have anticipated and you have started calcium infusion. Otherwise, you would have gone into severe tetany and probably seizures because this is a typical case of hungry bone syndrome.
Yes,
Yes.
sir.
The bone would have taken all the calcium the moment parathyroid was out.
So, to summarize the case, this is the case of primary hyperparathyroidism due to a large right inferior parathyroid adenoma in a 30-year-old male, presenting with the recurrent kidney stone, severe osteoporosis, and pathological fracture of the femur. The patient was successfully treated with the parathyroid surgery, which corrected the hormonal imbalance and calcium level. On follow-up, after the completion of treatment, calcium was started. Calcium was given in post-op period due to these findings. On follow-up period, after 1 month of the surgery, serum calcium and phosphorus albumin were performed, and showing that was found within normal limit. And the patient reported improvement in the pain and mobility, and no new complaint were noted. The fracture site showed progressive healing, and the immobilization were continued and managed as by the orthopedic advice.
Okay.
This is, sir, all over, sir, from the outside.
Are you interested in his osteoporosis? When would you do the repeat DEXA and check that to confirm that he is healing well?
Sir, within 3 months, sir.
No, not within 3 months. An year later, you can do a DEXA and see whether the healing is happening well.
Yes, sir.
Okay, I think we are past our time.
Okay, sir.
Dr. Ganavi,
Yes, sir.
I think we have only 30 minutes, I suppose.
Yes, sir. Yes, sir. For
Yeah.
the discussion, it's 30 minutes.
Yeah.
Yes, sir. So thank you, Dr. Ajay, for a very nice presentation. And I thank the moderators, Dr. Chitresh sir and Dr. Anish sir, for leading a very excellent discussion. So I now request Dr. Vijay Reddy sir to introduce our eminent speaker, Dr. Rajesh Khadgawat sir.
Thank you, Dr. Ganavi. It's a great honor for me to introduce Dr. Rajesh Khadgawat, sir. So, sir was my senior in SGPJ Lucknow, and he is currently Professor of Endocrinology at All India Institute of Medical Sciences, Delhi. He will be talking on important practical topic, which is of importance, thyroid autoimmunity during pregnancy, its importance in management. So we know that autoimmune disease is the most common cause of thyroid disease. And during pregnancy, there is a lot of controversy about autoimmune thyroid disease. So to talk on this, we have Dr. Rajesh Kadgawar, sir, Professor, Department of Endocrinology, AIMS, New Delhi. And he's got multiple publications, more than 233 index papers, and 35 best paper awards. So over to you, sir.
Thank you. Thank you, Dr. Vijay, for nice introduction. I'm apologetic because my throat is not well. I'm suffering from sore throat, little bit better today. And then my extreme gratitude to Dr. Pramila for giving me this opportunity. So my uh, laptop's camera is not working, so I'm switching off my video and then joining with my slides. So, Dr. Vijay, my slides are visible?
Yes, visible,
Yes, the
visible.
slides are visible.
And I'm audible also, although
Yes, sir.
Yes,
sound
yes,
is not
yes.
good.
Good, sir.
So, briefly, I would be discussing thyroid autoantibodies. We have different types of autoantibodies, so when to order and with the special reference where there is maximum importance of thyroid antibody comes is during pregnancy. As Dr. Vijay said, it's commonest organ-specific autoimmune disease affecting up to 5% of the population, both HLA based and non HLA based, and including antibody generation is the part of that, resulting from the complex interaction between environmental and genetic factor. And nowadays, more and more new factors are coming, which are suspected to start the triggering. One of them is gut microbiota, smoking, many new environmental factors, especially the endocrine disrupting chemicals, and then many more things. And two important autoimmune thyroid diseases are Hashimoto's and Graves' disease. These are our markers of autoimmunity, and two important antibodies which makes our life worse is TPO and antithyroglobulin antibodies. TSH receptor antibodies are only important when we are talking about thyrotoxicosis, and IS antibodies are mostly used in research setting, and there are many other antibodies against thyroid antigens, mostly in research, not in service side. So thyroid antibodies, these are 5 times more common in women than in men. We do not know exact reason why autoimmunity is more common in men. Probably role of second X comes into picture, or probably role of estrogen, higher estrogen come into picture. But this is not for thyroid autoimmunity, but this is true for other autoimmunities also. And selected groups are at risk for thyroid autoimmunity. These are younger women, relatives of patient with autoimmune thyroid disease, on whom incidence is higher, and much higher risk factor is the family with autoimmune thyroid disease. Low levels of antibodies with the unknown significance is also seen in subjects with a normal thyroid function as well as non-thyroidal illness. So how prevalent these antibodies? This is table from our Williams. If we talk about general population, anti-TSH receptor antibodies are almost not detectable, but anti-TG antibodies 5 to 25%, and TPO antibodies again in the same range, 5, 8 to 27%. But they becomes more prevalent if we talk about Graves' disease. 80 to 95% of Graves have anti-TSH receptor antibody, but TG and TPO antibodies are also quite common, 50 to 80%. Autoimmune thyroiditis, again 20 to 10 to 20% of autoimmune thyroiditis do not have anti-TG or anti-TPO antibodies. But most important thing is relatives of patient with autoimmune thyroiditis who have absolutely thyroid function, they have also chance of 30 to 50% positivity of TG and TPO antibodies. Also seen in type 1 diabetes with euthyroid function, and then again in pregnancy, autoimmunity becomes more common with the reference to anti-TPO antibodies. So anti-TPO thyroid peroxidase, we know that it's a glycoprotein present on the apical surface of thyroid follicular cells. Its function is to iodize oxine, oxidize iodine. It converts iodine to iodide, and then this iodide is attached to the thyroglobulin and then converted to MIT and then DIT, and then we have T3 and T4 synthesized. So this cell surface antigen is involved in the cytotoxicity. TPO binds, antibodies bind with TPO to form an immune complex, which triggers both ADCC as well as complement mediated cytotoxicity. And these cytotoxicity results in are produced by the lymphocyte, which infiltrate thyroid as a result of binding with the antibodies, and its titer is positively correlated with severity of infiltration. So if we see on FNAC or histopathology, more severe infiltration means higher TPO antibodies. There are many commercial methods available, including ELISA, but nowadays the best method is chemiluminescent immunoassay, for which only serum or epenrized plasma should be used. Different assays have different cutoffs, but normal levels in most of the assays are considered less than 35 IU. 2 to 3 times of increase in the TPO level, maybe up to 100 IU per ml, is considered not strongly positive. Maybe batch variation also, but anything more than 100 IU per ml is considered as a TPO positivity. Range of assay is quite large. It can measure up to 1000 IU, but since the TPO levels may be very high, so high dose hook effect is also seen in these cases. If levels are very high, there is hardly any interference in this assay. However, sometimes heterophil antibodies can cause falsely positive result, but these antibodies are not common in terms of when we are talking about anti-TPO antibodies. Which method is best and which lab is best? Again, there is hardly anything to suggest that, because of the different epitope recognition of antigen in different antibodies and different assays. So it's always advisable, if you have done for one patient, if you have done one sample with one lab or one kit, it's always better to repeat the same autoantibody assay consistently, so we can grade the severity of rise or fall in the TPO antibodies. So it may also be possible that TPO antibodies are positive and still thyroid function tests are normal. So do we have Hashimoto's thyroiditis? 60 to 90% have TPO antibody positive, but again, a good amount of Hashimoto's thyroiditis who are FNAC proven can be TPO negative also. So it doesn't predict the diagnosis. Diagnosis is based on the lymphocyte infiltration of the thyroid, confirmed on that. If there are higher antibody level, generally they do not predict the faster progression of thyroid destruction. It may be mildly elevated TPO antibodies, or it's severely increased antibody levels do not suggest that higher levels are associated with the faster progression. Similarly, antithyroglobulin antibodies, these are again macromolecule in the thyroid follicle. Like TPO antibodies, these are not cytotoxic or complement fixing, and their sensitivity limit varies widely, and their association with TSH is not very strong. So elevation of thyroglobulin antibodies usually appears with the TPO antibodies, and there are very uncommon situation where TPO antibody is negative and thyroglobulin antibodies are positive. These antibodies, they do not suggest any specific diagnosis or any thyroid disease. They are more associated, primarily used with differentiated thyroid cancer as an adjunctive to TG measurement. So thyroglobulin antibodies are also common in autoimmune thyroid disease. Major drawback is their lack of specificity. 10 to 11% general population will have. They do not play routine role in diagnosis of autoimmune thyroid disease. So whenever we are measuring thyroglobulin level in case of DTC or diffuse differentiated thyroid cancer, because of the anti-thyroglobulin antibodies, the levels may come of thyroglobulin as normal. So it's customary to measure both thyroglobulin as well as anti-thyroglobulin antibodies. So where comes the significance of TG and TPO antibodies? They may be high elevated in non-autoimmune thyroid disorders, maybe in sporadic goiter or isolated thyroid nodules, or maybe low levels of these antibodies may present in subacute thyroiditis, or maybe in the other autoimmune diseases, particularly type 1 diabetes. So it's not very specific for diagnosis of autoimmune thyroid disease. Do they have any pathogenic role? They usually do not have any pathogenic role. They cannot transfer disease from mother to fetus, even though they can cross placenta. They may contribute to disease mechanism, but not responsible for starting damage to the thyroid. TPO antibodies correlates well with the thyroid damage and lymphocytic infiltration, but still they are not initiating the thyroid destruction in case of Hashimoto's thyroiditis. So where do we use TPO? Just damage, just denote the thyroid damage, does not causes thyroid disease. Higher levels of TPO antibodies means higher thyroid infiltration by the lymphocyte. If there is progressive rise in TPO antibodies, it suggests that there is ongoing damage. However, they are not useful for diagnosis and prediction of thyroid disease. Only limited indication is measuring during pregnancy. Thyroid globulin antibodies have no role except differentiated thyroid cancer. TRAB antibodies, in comparison to that, are more specific for the diagnosis. They are both stimulatory antibodies or blocking antibodies. They have direct pathogenic role in Graves' disease. 99% of untreated Graves or 90% treated Graves with carbimazole, they will have TSH receptor antibodies, or even if they are in remission, antibody remains positive. And in normal individual, there is hardly any detection, and most of the time it's less than 1% of the normal population. Clinical utility of TSH receptor antibodies is they are highly sensitive and specific to the extent of 97 to 98%. They are helpful in diagnosis of thyrotoxicosis, especially when we are in confusion. If there more than one nodule is present, we are not able to make diagnosis. So in that case, if TSH receptor antibodies are present, it suggests diagnosis of Graves' disease. Positive TSH antibodies are there, we consider diagnosis of Graves' disease. So need of thyroid scintigraphy, which is not widely available, becomes questionable. Or sometimes patient comes with the thyroid eye disease, but euthyroid. So in that case, positive TSHR antibodies suggestive of Graves' disease. And whenever there is confusion of fetal or neonatal thyrotoxicosis, can also get some guidance from the TSH receptor antibodies. There are many studies based on the TSH receptor antibodies showing the chances of remission of hyperthyroid if the levels are high and they fall during treatment with anti-thyroid drug. There are more chances of remission, but this information has not been widely replicated in most of these studies. But initial studies have shown that if TSH receptor level antibodies are high at the time of diagnosis, if they goes down during treatment period and become undetectable, there are more chances of going into remission. Now comes the pregnancy. So it's a pregnancy is like TMT of the thyroid gland. During pregnancy, thyroid gland increases in size, produces more 50% T4 and T3, requires more iodine. Normal TSH range is compressed at the both end of the spectrum. So it's a physiological stress test for thyroid. So what happens to these antibodies? So various studies have shown that 2 to 17% of unselected pregnant women, they have TPO antibodies. And this prevalence varies widely with ethnicity, more frequent in Caucasian, Asian women, least frequent in African Americans. And these antibodies can cross placenta but do not affect the fetal thyroid. As pregnancy increases, there is decrease in the prevalence and titer, and toward the third trimester of pregnancy, the levels become quite low. So this is maternal placental fetal thyroid traffic. You can see that everything is crossing except TSH, thyroglobulin, and HCG antibodies. They can cross freely across the placenta. T3, T4 to certain extent are also crossing. And this autoimmune thyroid disease during pregnancy, TPO antibodies have shown associations with pregnancy events, shown with infertility, failure of assisted reproductive technology, sporadic and recurrent miscarriage, premature delivery, GDM, hypertension, abruption of placenta, premature rupture of membrane, and postpartum thyroiditis and depression. These are the various perinatal events with the TPO antibody has association. Just to showing study, this is one meta-analysis published, which shows that euthyroid women who are positive for thyroid antibodies have significantly increased risk of unexplained fertility compared to those women who were negative, and this has been reported in many other studies. Also, similarly, association with the spontaneous miscarriage has been well reported in meta-analysis. If your TPO antibodies are positive, levels are higher, you have more chances of spontaneous miscarriage. Uh, Also associated with the recurrent miscarriage as well. Thyroid autoimmunity is also associated with the preterm delivery. This was reported very early and in 2012, and meta-analysis reported that overall relative risk of premature delivery in euthyroid women is 1.98, which was statistically significant. Postpartum thyroiditis is the area where TPO antibody positivity has consistently reported and most commonly occurs early after delivery, usually 6 weeks to 3 months, but can occur up to 12 months postpartum. Overall incidence of postpartum thyroiditis is approximately 8%. It has been seen those who have thyroid autoimmunity in form of TPO positivity, they have higher risk presence of thyroid antibodies during pregnancy. One of the best predictor has been reported, and those who have TPO antibodies, they have 5.7 times higher risk of developing postpartum thyroiditis compared with without a woman with without antibodies. And these are the various meta-analysis. However, no clinical trial has compared the treatment algorithm for postpartum thyroiditis, including timing and choice of patient. So if we just revise the association of TPO antibody positivity, so all these diseases, there is a clear result, especially spontaneous miscarriage, recurrent miscarriage, premature delivery, and postpartum thyroiditis are shown strong association with the TPO positivity. So is it possible that TPO positivity is there? So if we give thyroid supplementation, can we prevent these events or can we treat these events? So this is again confusing area. If there is subclinical hypothyroidism, benefit has been reported in most of these studies. Euthyroid subject with TPO positivity, there is again doubtful results. Some studies showing supplementation is advantageous, others are showing there are no benefit, and other studies are also showing that there are disadvantages of giving thyroid supplementation if thyroid functions are normal. So not strong, only few studies have reported. Until then, we saw that two large size studies published. This is a tablet trial published in NEGM in 2019. What they did was, this was a double-blind placebo-controlled trial carried out in 49 hospitals of UK. And they selected those married women who were having normal thyroid function and TPO positivity. So these 16 to 40-year subjects were selected who had history of miscarriage or infertility, and they are planning to become pregnant in next 12 months. So such 952 women were selected, and they received either 50 microgram thyroxine to half of the women and placebo to half of the women. This was started well before conception and continued throughout the pregnancy, and the primary outcome was live birth weight after 34 weeks of gestation. So if we see the primary outcome of live birth rate, absolutely no difference between these two groups. Relative risk was 0.97, which was not significant. And not only primary outcome, none of the secondary outcomes related to pregnancy or neonatal outcome were also not significant. So there was no difference in primary or secondary outcome if we give thyroxine to those women who have TPO positivity but euthyroid. So this tablet trial concluded that no significant difference in rates of live birth after at least 34 weeks of gestation, with use of 50 microgram levothyroxine once daily, started before conception and continued throughout pregnancy among euthyroid women with TPO antibodies. Although there was some criticism of the study as they used the fixed dose of levothyroxine, and during these time when this study was published, another famous study, T4 Life study, this multicenter randomized double-blind placebo-controlled trial carried out in Netherlands, Belgium, and in Denmark. Similar kind of patient selection, TPO positivity, normal thyroid function test, and treatment was started before conception, and daily dose of levothyroxine was given to keep the TSH concentration normal range from 0.5 to 1 microgram per kg body weight, and again primary outcome was live birth weight beyond 24 weeks of gestation. So 94 weeks in levothyroxine, 93 in placebo group. Again, primary outcome, there was absolutely no difference. And they also concluded that compared with placebo, levothyroxine treatment did not result in higher live birth and in euthyroid women with recurrent pregnancy loss and who were positive for TPO antibodies. Another study published in BMJ in 2017 with the subclinical hypothyroidism, which was treatment started 4 weeks before or 3 months after pregnancy. Primary outcome was pregnancy loss with multiple secondary outcome. Around 405 women were recruited, and 843 received thyroxine and 4,500 did not receive thyroxine. They reported that pregnancy loss was significantly less among treated women. But after all adjustment, treated women had 38% lower rates of pregnancy loss. But at the same time, there was some concern with the treatment. The treated woman has higher adjusted odds of premature delivery, preeclampsia, and gestational diabetes. So it's not only unsafe, there are higher risk also if we treat only euthyroid women with TPO positivity. So they concluded that treatment of subclinical hypothyroidism resulted in significant less pregnancy loss in comparison to those who were not treated. At the same time, treatment was associated with significant risk of premature preterm delivery, GDM, preeclampsia. So benefit of thyroid use in pregnancy loss was observed not only women with pre-treatment TSH, but not those with if their TSH levels are normal. So subclinical hypothyroidism, yes, there are benefits, but there are no benefits of treating if thyroid function levels are normal. So if we see the available evidence, association has been reported, but you can see that there is no benefit of thyroxine supplementation has been reported in these conditions. So what American Thyroid Association suggests, so this is based on 2017 guidelines. So they suggest that thyroxine therapy in during pregnancy is required if TPO is positive and TSH is more than 4. If TPO is negative and TSH more than 10, it's clearly recommended. TPO therapy, thyroxine may be considered if TPO positive and TSS between 2.5 to 4, but there is no strong evidence. If TPO is negative and T4 is more, the better evidence is available of treatment. And thyroxine therapy is definitely not recommended for TPO antibody negative and TSH less than 4, or TPO antibody positive, TSH is less than 2.5. These are the categories where no thyroxine therapy is required. This is guidelines published by the gynae people in association with the Indian Thyroid Society. Similar kind of recommendation they have also given, and this is latest consensus statement from Indian Thyroid Society, for which we are doing this series today. So what they have recommended during pregnancy is thyroid function test. There should be a specific cutoff available for each trimester. If not, then we can use upper limit of normal as 4. Women with positive TPO antibodies, hypothyroidism during course of pregnancy are at higher risk of multiple complication. TPO status should be assessed with a TSH if more than 2.5 and less than 10. Thyroxine treatment for those who are having TPO positive and TSH is above pregnancy specific range means if they are having subclinical hypothyroidism, the TPO antibody positive, they should be treated. But in any case, more people use whether antibody positive or negative. If it's subclinical hypothyroidism, it has to be treated. So thyroxine treatment or TPO antibody positive euthyroid woman with the prior history of pregnancy loss can be considered on case to case basis, although evidence has not shown any advantage in preventing the pregnancy loss. So just to summarize my presentation, association with thyroid autoimmunity and pregnancy events are reported, especially miscarriage and preterm delivery. Current guideline evidence is insufficient to recommend for or against the universal screening of thyroid antibodies. If TSH is less than upper limit of normal, antibody positive or negative, treatment may not be required. If TSH is more than 2.5 and less than upper limit of normal, again, antibody positive or negative treatment may not be required. But if TSH is more than upper limit of normal, antibody positive, treatment is required. And the last situation is TSH is more than upper limit of normal, plus TPO antibodies are negative. So in this situation also, most of the physicians prefer to treat because TSH is higher than the upper limit of normal. So this again makes a ground for treatment, although guidelines not uniformly suggest, but TSH higher than the upper limit of normal makes a ground for starting treatment in these cases. So these are the emerging thyroid antibodies. Multiple antibodies are there, and these antibodies are still not in service sector. They are in research mode and yet to be proven association with the autoimmune thyroid disease. So thank you very much for your patience-full hearing. So this is all from my side. Thank you.
Thank you, sir, for a very comprehensive presentation, clearing numerous controversies regarding the management, especially related to autoimmunity in pregnancy. In fact, it is considered to be one of the burning issues as well. So, moving on, a very short announcement before we proceed to the quiz, which is the next session. So, those who are interested to submit their research to our flagship journal, that is the Thyroid Research in Practice, can do so by scanning the QR code. And those who are interested to become a reviewer for Thyroid Research in Practice can do so by scanning this QR code displayed on the screen. So, and now for the most awaited segments of today's session. So that is the ITS Thyroid Clinics quiz. And our quiz master for the evening is Dr. Abhijit Javanjar. He's a consultant endocrinologist at Eklavya Hospital as well as Javanjal Diabetes Endo Eye Super Speciality Clinic, Akola, Maharashtra. He has been a student as well, one of our very good students. So it gives me immense pleasure to introduce him. He has numerous supports to his credit and has also has numerous publications also, and also has a life membership of numerous societies as well. So moving on, let us briefly go through the quiz instructions. Yeah, so to participate in the quiz, click on the button that is the Attend Quiz button, which is displayed on the screen. This is being live streamed. This quiz will be conducted through a platform called the Slido. You are requested to use a laptop for the ease of experience. The quiz will run for 5 minutes. The quiz master will display the quiz, the case or the description of the question by screen sharing a PowerPoint file. There'll be 10 questions. Each question will be available only for 30 seconds with the timer on. So do not refresh the page or go back to the previous page. So with that, I invite Dr. Abhijit to proceed with the quiz.
Thanks a lot, ma'am, for that very kind introduction. And I would like at the onset to thank Pramila ma'am, Chitra ma'am, and Ganvi ma'am, and Vijay sir, obviously the whole ITS team for giving me this opportunity to conduct this quiz. And I have been a regular participant of this quiz for last 3 years, and now conducting a quiz that gives me a proud. So we'll be starting with the quiz now.
Sir, we will do the screen share first, sir. So I'll give you the cue when to move to the next question, sir. Yeah.
Okay.
You'll just screen share on the first page itself, and
Yes.
we'll wait for a minute or two, sir. People are
Yes.
joining now. Yeah. Just go to the slide mode, sir. Slideshow. Yeah, we'll wait for a minute, sir. I'll tell you when to go on to the next screen. And then after
Yes.
each question that gets finished, and once everybody answers, I'll tell you to move on to the next question, sir.
Yes.
Yeah, thank you. We'll wait for a minute, sir. Sir, we'll start with the questions.
Yes. So coming to the first question, here a 32-year-old woman presents with palpitations, and a lab report shows a TSH of 6.8 with free T4 and free T3 elevated, and alpha subunit is normal. SHBG is also normal. So what is the most likely diagnosis? Option A, THS secreting pituitary adenoma. Second, B, assay interference. C, thyroid hormone resistance to TSH receptor beta, or a factitious thyrotoxicosis.
I'll give you the cue, sir, when to move on to the next question. We'll wait.
Yes.
So next question, sir.
So second question, standard protocol for the thyroid hormone withdrawal that is to be done before radioiodine ablation includes stopping of LT4 therapy and switching to LT4 therapy when we should do it. Option A, 2 to 4 weeks of followed by withdrawal of levothyroxine, that is levothyronine, for 1 week. 2 to 4 weeks of withdrawal of LT4 followed by withdrawal of LT3 for 2 weeks. 4 to 6 weeks of withdrawal of LT4 therapy and followed by withdrawal of LT3 for 1 week. Or the last option is 4 to 6 weeks followed by withdrawal of levothyronine for 2 weeks.
So next question, sir.
So coming to question number 3, zinc, which is a important mineral, which is used for which has an important role for thyroid function. It is necessary for which of the following processes? Like option A, it helps for the enzyme 1,5 dash deiodinase, which catalyzes conversion of T4 to T3, or enzyme 1,3 dash deiodinase, which catalyzes conversion of T4 to T3. Option C, is it 1,5 dash deiodinase, which catalyzes the conversion of T3 to reverse T3, or the last option, that is 1,3 dash deiodinase, which catalyzes conversion of T3 to reverse T3.
Next question, sir.
So coming to the important topic, what we discussed today, like regarding thyroid antibodies. So whenever there is a trap positivity with normal TSH, despite of being on treatment with antithyroid drug for more than like 1.5 year, what is the next best option? Is it option A, continue antithyroid drugs for 1 more year? Option B, continue antithyroid drugs for 5 more years. Option C, continue ATDs till the TRAB is negative. Or option D, refer for definitive treatment, that is radio iodine ablation or total thyroidectomy. That is the last option.
So next one, sir.
Coming to question number 5, the agents that stimulate thyrotropin secretion. All of the following these stimulate thyrotropin secretion except option A, arginine vasopressin, that is AVP. Option B, that is GLP-1, glucagon-like peptide. Option C is galanine, or option D, is it serotonin?
So next one, sir.
Coming to the option, question number 6, the prevalence of TSH receptor antibody in pregnant woman. Is it 0%? Option B, 1 to 5%. Option C, 5 to 10%. Or is it D, 10 to 15%? This topic already sir has covered in detail.
So next one, sir.
Coming to the question number 7, that is prevalence of anti-TPO antibody in euthyroid pregnant woman in India. Is it option A 10%, option B 20%, option C is 30%, and option D is 40%? Previous question was regarding TSH receptor antibody. This is regarding anti-TPO antibody.
So next one, sir.
Coming to question number 8, which of the following is false regarding thyroid autoantibodies? That is the anti-TG and as well as anti-TPO antibodies. So option A, these antibodies appears to be a secondary response to thyroid injury. They are polyclonal in nature. That is options B. All of them, they are restricted to one particular immunoglobulin, that IgG subclass G. Or the last option, they can cross placenta. So which of the following is false? You have to select of these 4 options.
So next one, sir.
Coming to the question number 9, which of the following is false regarding TRAB antibodies in pregnancy? Option A measure in first trimester. If undetectable, measure again at 18 to 22 weeks of gestation. If option B, if they are elevated more than 3 times the upper limit of normal, it necessitates the close fetal monitoring. Option C, they can determine the necessity of ATD treatment during the teratogenic period. And option D, these antibody help in differentiating Graves versus transient gestational thyrotoxicosis, like hyperthyroidism. So you have to select false. in pregnancy about these TSH receptor antibodies.
So next one, sir.
Okay, coming to the last question. This is the recent update that DYRK1A expression is overexpressed in individuals in which of these subsets? Like option A, type 1 DM with hypothyroidism, type 2 DM with hypothyroidism. Is it a Down syndrome with hypothyroidism or Down syndrome with hyperthyroidism? This is from the recent publication from our own country.
Done, sir.
Thank you.
Abhijit, you can discuss the answers for the DM quiz, then we can come to the results.
Yes, sir. This will be for practitioners quiz, right, sir?
No,
Next.
DM quiz. DM quiz you finish.
DM quiz. Okay. Is it visible, sir?
Yes, it's visible.
Okay, so coming to the discussion part, coming to the first question, the 32-year-old woman who presented with palpitations and the lab report showed increase in TSH and free T4 as well as free T4, free T3 were elevated, and alpha subunit was normal and SSVG was normal. This typically points towards syndrome, what we call as thyroid hormone resistance to receptor beta. In that, this is directly taken from our flagship journal of that thyroid hormone and research. And as we know, whenever there is a resistance which at the TSH receptor beta levels, we have this kind of presentation in the form of palpitations and mimicking thyrotoxicosis. And in that, typically SHBG levels are normal, and alpha subunit, which is high in the pituitary adenoma, that is also normal. Coming to the second question, this is regarding the thyroid hormone withdrawal, which is usually done before planning for radioiodine ablation. It includes stopping of LT4 therapy 2 to 4 weeks, followed by withdrawal of LT3 therapy for 2 weeks. This is the correct answer. That is option B. This is also taken from our the same thyroid research and practice guidelines, and this is from the consensus statement by ITS of withdrawal, thyroid hormone withdrawal. Coming to the third question, that was regarding this micronutrient of zinc. So it is crucial hormone for thyroid function, and the correct option for this is catalyzes this. It stimulates the enzyme 1,5-deiodinase, which catalyzes the conversion of T4 to T3. So option A is the correct answer. Coming to question, and this is also taken from our flagship journal of thyroid research and practice. Coming to the fourth question, so this is a practical question. Like we usually find this patient of anti-TPO positivity with normal TSH, despite of treating for more than 1.5 years. What is the next best treatment? So in that, the correct option is continue ATDs till TRAB is negative. That is option C. This is taken from the Endocrine Society guidelines. approach of patients considering long-term antithyroid medications with Graves' disease. If we give treatment for like 1.5 years, still the TRAb titers are high, we have two options, either to go for long-term ATDs or to go for definitive surgeries. And if TRAb is normal, then we can consider stopping the treatment. Coming to the question number 5, agents that stimulate the thyrotropin secretion, all of the following except in these, the correct option is serotonin. This is directly taken from our the standard textbook of Williams. In that, there are different agents which stimulates the thyrotropin, like TRH, prostaglandin, arginine, vasopressin, GLP-1, and galanin. So serotonin is the correct answer. Coming to the question number 6, this is discussed already today by Rajesh sir. So prevalence of TSH receptor antibodies in pregnant women, and the option correct answer is 0. So these are more specific. So they are used for diagnosis of Graves' disease, and this is taken from Williams textbook. Coming to the another anti-TPO antibody in euthyroid pregnant women, the prevalence is in India is almost up to 18 to 20%. So the correct answer for this question is option B, and this has been taken from our own Thyroid Research and Practice journal, where estimated prevalence was found to be around 18.9%. Coming to the question number 8, so which of the following is false regarding thyroid autoantibodies? So this also sir has covered. So they appear to be a secondary role, not a primary. They are polyclonal in nature, and they are not restricted to one particular subclass of immunoglobulin. So the false option is option C, and this is true. They can cross the placenta. This also has been taken from our the important standard textbook of Williams. Question number 9, false regarding TRAb antibodies in pregnancy. So what is the false we had to select, right? So this is the option A is the false statement, where measure antibody in first trimester, and if it is undetectable, there is no need to measure subsequently. But this is the false option, and especially if levels are more than 3, then definitely it warrants close fetal monitoring, and it can determine the need of ATDs during thyroidogenic period, and also important one to differentiate between Graves and transient thyrotoxicosis, gestational thyrotoxicosis. So this also we have taken from the Thyroid Research and Practice Journal, regarding the TSH receptor antibody. Coming to the last question, DYRK1A expression, and this is overexpressed in individuals from the patients with Down syndrome with hypothyroidism, and this has been recently published in the month of January 2026 by Sujay Ghoshar and the team from IPGMR. So they have found that DYRK1A expression was overexpressed in patients with Down syndrome with hypothyroidism. Thank you. Thanks.
Thank you, Dr. Abhijit, for informative quiz and covering detailed aspects of thyroid autoimmunity in most of the questions. I think many guidelines and consent statements are published in Thyroid Research and Practice Journal. I encourage all of you to have a look at Thyroid Research and Practice articles and the consensus statements and the recommendations. Tech team, can we have the results of the DM quiz?
Yes, sir. We are displaying.
Sure. Congratulate all the winners. The first prize goes to Dr. Shravani, second Dr. Kavya, and third Dr. Akshita. Congratulations to all the winners of the quiz, and you will receive a letter of appreciation and certificate from the Indian Thyroid Society by email. Doctor, we already conducted the practitioners quiz online through the link which was provided with the invitation flyer. Dr. Abhijit, you can discuss the answers, and then we will release the results of the practitioners quiz.
Yes. So coming to the questions for practitioners, what we had conducted. So preferred modality of imaging in patients with thyroid nodule, the correct option is ultrasound thyroid. So this is also taken from consensus statement of the thyroid research and practice, where whenever there is a suppressed TSH, the whenever there is the nodule with euthyroid patients, it is usually recommended first choice is ultrasound, and scintigraphy is not recommended in case of normal or elevated TSH. So whenever there is a suppressed TSH, or for that matter, then the other modalities are important. The primary hypothyroidism is considered treatment refractory when the residual symptoms of hypothyroidism or biochemical signs of hypothyroidism persist despite of increasing dose. The correct option is more than 1.9 microgram per kg per day. That is a indication to label as a refractory hypothyroidism. This is also taken from thyroid research and practice. Question number 3, in patients with myxedema coma, the recommended loading dose of liothyronine, it is actually from 5 to 20 microgram, and the correct option is 10 to 20 microgram. This is also from the consensus statement regarding the liothyronine therapy in patients with hypothyroidism. Coming to question number 4, which of the following was a genetic mutation can be associated with MTC, that is medullary thyroid carcinoma? So correct option is red, which is a proto-oncogene located on chromosome number 10. And this, as we know, almost 20% of these cases are familial. So these are associated with MEN 2A, 2B, and familial MTCs. And these are caused by mutation in red proto-oncogene. Coming to the question number 5, this was regarding a patient on amiodarone therapy who had presented with thyrotoxicosis, and Doppler showed increased velocity, vascularity. And thyroid autoantibodies were negative, and there was a background of background MNG was present. So best treatment, the option was option C, that is a methimazole. So this is a typical case of type 1 amiodarone-induced thyrotoxicosis, where the initial treatment of choice is thionamides, that is carbimazole or methimazole, and while the type 2 is amiodarone-induced thyrotoxicosis, where glucocorticoids are the mainstay of treatment. This is the question number 6, where this is a clinical finding which is labeled as a Means-Lerman scratch, which is usually related with hyperthyroidism, and it is a scratchy sound, systolic rubbing sound of hyperdynamic pericardium against the pleura, and it was named as a Means-Lerman scratch. Question number 7, in elderly patients with age more than 65 with subclinical hyperthyroidism, that is TSH less than 0.1, treatment is recommended to reduce the primary risk of which of the following conditions. So the correct option is atrial fibrillation, and this is also from the guidelines of European Thyroid Association, where it is given that grade 1 recommendation to treat hyperthyroidism above 65 because there is a risk of atrial fibrillation. Coming to question number 8, where the non-thyroid illness or sick euthyroid syndrome, it is characterized by all of the except. So the correct option was decrease reverse T3. The correct actually it is the increase reverse T3 production which occurs in this sick euthyroid syndrome. This is also taken from our flagship journal of thyroid research and practice. Coming to the question number 9, a 42-year-old patient presented post-thyroidectomy, had a calcium of 8 and serum albumin of 2.6. So what is the corrected calcium there? And the correct option is 9.2. This is the common formula every one of us should, the practitioner should know. That is a measured calcium plus 0.8 with 4 minus albumin. So correct option here comes 9.2. And another clinical sign, question number 10, this is last question. Hung up ankle jerk in hypothyroidism is known as, the correct option is Voltman sign, and this is named first described by Henry William Voltman, which is typically the reflexes are slowed down in hypothyroidism, and this is the name sign.
Thank you, Dr. Abhijit, for the informative quiz. I think we had a lot of learning points from both the quizzes. Tech team, can you put the results of the practitioners quiz? congratulate the winners. First prize goes Dr. Mohammed Kaus, second Dr. Chandra, and third Dr. Gunasudha. Congratulate all the winners. You will receive a letter of appreciation and certificate by email from the Indian Thyroid Society. Over to Dr. Ganavi.
Yes, sir. Thank you, Dr. Abhijit. It was definitely a very captivating quiz and for discussing the answers as well, very briefly. So, as we conclude today's session, I'd like to invite Dr. Pramila Madam to share the closing remarks.
Yeah, thanks, Dr. Gandhi. I think we had an excellent discussion today, starting with the case on primary hyperparathyroidism and presented by Dr. Ajay and moderated by Dr. Chitresh and Dr. Anish. And then we had a very interesting lecture by Dr. Khargawat on the TPO antibodies and the various other antibodies in pregnancy and how do we take care of that and how do we treat subclinical hypothyroidism in pregnancy and when do we treat. And it was nice to see Dr. Abhijit, our previous student, doing so well and doing such a fantastic quiz. And I think it's nice to see your student doing so well in their academics and in their practice as well. So I think we also should thank Dr. Vijay Bhaskar Reddy for conducting all the proceedings so nicely. So I thank everybody for today's excellent discussions. And I also request everybody, all the audience, students, and the faculty who are there, to submit your research to Thyroid Research and Practice, which is our flagship journal of the Indian Thyroid Society. And also to please, for the faculty, to please become reviewers of Thyroid Research and Practice, because we need good reviewers to publish good articles. So I also thank my other team members who are part of the Indian Thyroid Society Thyroid Clinics team. And with that, I hand it back to Dr. Gandhi to carry the proceedings and tell the date of the next ITS clinics.
Yes, ma'am. Thank you, ma'am. So our next thyroid clinic session is scheduled for 8th April. We request everyone to join for the same. So to conclude, thank you all for joining, and we look forward to hosting you the next time. Thank you all. Good night.
Thank you. Good night, everyone.
Thank you.
तस्य भास सर्वमिदं विभाति